Our next two speakers are leading innovative collaborative efforts to improve access to care in their states. We're now joined by Dr. Mark Jansen, Vice President and Chief Medical Officer for Arkansas Blue Cross and Blue Shield. Arkansas Blue Cross and Blue Shield is committed to serving rural communities by addressing issues related to social determinants of health and improving access to health care. As a leader and partner in statewide efforts, Arkansas Blue Cross and Blue Shield has spurred dialogue and collaboration among key stakeholders to fill gaps in care in rural Arkansas. Dr. Jansen has been a critical part of these efforts, and we will hear today about many of Blue Cross's innovative initiatives. Dr. Jansen brings his own unique experience to our conversation today as a self-proclaimed country doc in Southwest Arkansas for over 3 decades. He also spent the last 6 years educating primary care physicians at the University of Arkansas for Medical Science, both on their central campus and on affiliated regional programs in 8 rural locations. Dr. Jansen has a special interest in rural healthcare sustainability and workforce development, and we're so pleased that he could join us here today. Dr. Jansen?
Thank you very much, Catherine. I appreciate as well the opportunity to present my information to this webinar and also to NIHCM. So you heard a little bit about my background. Yes, I am a self-avowed country doctor, reformed now to the city, but still have rural citizens and rural medicine in my heart, and I'm giving this presentation from that perspective. So Arkansas, back in the 1900s, our state was 90% rural. The rest of the country was 60%. You see the lines before you. There's been a decrease in the rural population where we are now approximately, as of the last census, 44%. About every 2 years, the University of Arkansas Division of Agriculture, Research, and Extension will provide an excellent report. It's available online, the Rural Profile of Arkansas. And in their 2019 report, one of the summary highlights was that the rural areas had only about 70 primary care physicians per 100,000 as compared to the urban areas of the state, which had approximately 170. Family physicians are important in the rural area. We know that only 15% of the production of the workforce is family medicine, but they provide 42% of the care in the rural areas. A busy slide, bear with me. Let me tell you about my research. So this was 2015. I just had a suspicion that we were already looking down the barrel of a physician crisis, particularly in the rural areas. So I went to the Medical Society, got a list of all the self-identified general practice, family medicine, and primary care internal medicine physicians in the state. I then excluded the top 10 most populous cities to create a rural subset and plotted number against age. So the graph that you see before you, if you can't read the fine print on the bottom, the tallest bar in the center is age 60. The cohort, there are 23 in that group, and then you can see right behind that a precipitous fall in the number. Shift all this in your mind 4 years into the future. The 60-year-olds are now 64. They're approaching retirement age. And very shortly, we are going to have an issue with that I think is going to be dramatic regarding provider accessibility in the rural area. Oftentimes, when this type of crisis occurs, there are various solutions that are recommended, legislative and otherwise, and there may be the impression that things are getting better because you see the bimodal curve start to rise again, only to fall more precipitously after about 16 or 17 years. So we have to do something to increase the number of rural physicians and providers overall in the rural part of the state. Arkansas has what we call the red counties. So this is looking at life expectancy. If you happen to live in the eastern part of our state, which is predominantly the Delta area, your life expectancy has diminished as compared to the longest lived in the northwestern corner by almost 10 years. We traditionally have been number 47, number 48 as far as overall health care and the health of the population per the United States. If you eliminated 10 of these red counties, we'd come up to about number 25. So it really illustrates how significant the disparity is in the rural Delta. Sometime back in 2015, Arkansas Blue Cross Blue Shield gave a $1 million donation, $1.3 million donation to the University of Arkansas for Medical Sciences to create the George K. Mitchell Endowed Chair in Primary Care. Dr. Mitchell is a physician still living, was a former president and CEO of Arkansas Blue Cross Blue Shield, and I was fortunate enough while I was at UAMS as an associate professor to receive this chair. And an endowed chair throws off proceeds that then can be used to do whatever is appropriate on behalf of the holder of the chair. So I elected to approach the Winthrop Rockefeller Institute. The Winthrop Rockefeller Institute is a sister organization of the University of Arkansas, and Governor Rockefeller this was Winthrop Rockefeller back in the 60s, was the governor of Arkansas. There's now an institute utilizing resources from that family to address problems in the state, and I approached them about the issues that we had collectively regarding rural health care, and out of that came the Rural Healthcare Summit. So we had an organizational meeting in 2016, and then in 2017, 18, 19, and again anticipating spring of 2020, we bring together approximately 60 individuals invited, coming from all walks of life. These are providers, both physician and advanced practice providers. We have mayors, hospital administrators, politicians, community health workers. We're really trying to gather a group of like-minded individuals who recognize the problem, and they come together to try to come up with some solutions. Arkansas Blue Cross Blue Shield, through its Blue and You Foundation, has been especially important to this group regarding funding. They've allowed us to perpetuate the program, and also we're able now to invite those who, again, come from the red counties, so the community health workers that might otherwise be financially disadvantaged to attend can now attend with no charge whatsoever. So it's been an important support of Arkansas Blue Cross Blue Shield. So what does this group do? In our last summit from 2019, these were the 2-year goals. Community health workers, this is a marvelous group of folks. Again, it's more rural than urban, and basically they're a grassroots healthcare delivery system that is out in the Delta in particular, but it's very difficult for them to have any formal recognition, so we are working to create a certificate program and acknowledge the contribution, as well as provide appropriate training for these individuals that actually go into the homes of folks that need assistance with negotiating health care. As you'll hear, non-emergent transport is a big deal in rural areas. It's hard to get from point A to point B, particularly if you don't happen to have a vehicle or have trouble affording gasoline. So we're looking at legislative solutions to this. The Medical School Consortium Working Group. So there's been the traditional allopathic school, University of Arkansas. We now have 2 schools of osteopathic physicians on either side of the state, and we're looking at ways to increase residency slots to increase the number of rural physicians in the state. We're also having a collaborative come out of that where there's a student organization. We also got the deans of all 3 schools to come together in a collaborative effort. I understand that was the first time that deans of all medical schools of a given state actually work cooperatively together toward a common goal. And then finally, Student Exposure Working Group. And what I'm talking about here is not the traditional high school student. We're going all the way down to the elementary school level, and we're trying to make kiddos in rural areas be aware of opportunities in healthcare, not just the traditional doctor and nurse areas, but coders, laboratory technicians, administrative folks, all the things that are required to run a rural healthcare delivery system. The Winthrop Rockefeller Institute wants to see their children move on to other things, and so their goal is to graduate programs and then move on to other needs in the state of Arkansas. And I will tell you that the Rural Health Summit is beginning to morph into the National Rural Health Association chapter for the state of Arkansas. Oddly enough, we're one of 7 states now that doesn't have a rural health association. And this is a critical deficiency because we, like other states, have real problems regarding sustainability of hospitals in the rural area. DeQueen, Arkansas is a small community in the piney woods of West Arkansas near the Oklahoma border. It closed this last year. As you're well aware, there are a number of rural hospitals, both in the state and in the nation, that are financially challenged. It was mentioned earlier the issue related to opioids, so we have the dubious distinction of having the second highest rate of opioid prescriptions in the nation. Alabama is slightly ahead or behind, depending on your perspective, of Arkansas. And it's a real problem here because despite having an issue, we're also very slow to adopt MAT programs. There's a common opinion in Arkansas that when you look at substitutive therapy with Suboxone, buprenorphine, and others, that this is simply providing one addictive substance in exchange for another. So, and again, that's a backward mentality in my mind, those of you who know the success of MAT programs, but it's a little bit of an uphill push for us here in the state. As was mentioned earlier, social determinants are more impactful for rural residents. The rural residents tend to earn almost $10,000 less on a per capita basis in the U.S. As was mentioned before, if you happen to be in a minority, this is even more substantial. 25% of children in the rural area live in poverty, and those folks are having to assess the Supplemental Nutrition Assistance Program more frequently. And then tobacco use. I know we've got all the vaping in the news right now, but tobacco use is more common among kids in rural areas, and we have a specific issue with dipping forms, smokeless forms of tobacco, which can create their own set of health problems. We have real and what I'd like to call digital transportation issues. So rural residents have trouble with the distances between their residence and the nearest healthcare provider. They have to travel a long distance. If you are traveling in a rural area, more than 50% of vehicle crash-related fatalities occur. It makes sense. Your velocities are going to be higher in rural areas. Should you be in an accident, the ability to have EMS get to your location is slow because of distance. And then if you know about the golden hour of trauma, the opportunity once you're collected by the EMS service and actually delivered to a trauma center, it's not uncommon for that to take a lot longer than 60 minutes, which increases the mortality rate. And then I want to bring the concept of what I would call the digital desert. So 53% of rural Americans lack access to what would be considered the minimum for high-speed internet, and this is going to create a challenge as we develop these web-based delivery systems. You have to have the opportunity to connect to the web at a reasonable speed to be able to take advantage of those. Behavioral health and mental health is an issue in the rural areas that create unique challenges. Again, those individuals have to travel long distances. They're less likely to have insurance for these services. Just as there are chronic shortages of regular providers, those that have special expertise in mental health are much more sparsely populated. You may be okay to say that you have a therapist if you live in LA or New York, but if you live in LA here, which we call Lower Arkansas, there's a real stigma of needing or reaching out for help for a behavioral health problem. And because the accessibility to care and recognition of these problems is poor in the rural area, it's not surprising that rural youth have a suicide rate twice the typical average. So what do we do about the provider shortage? This was a Pew Charitable Trust article from 2015, and it's recognizing that the solution is not to create more medical students. The solution really is to look at how we create more residencies, because we know that a physician, a graduate from a medical school who stays in the same state to do an accredited residency and becomes board certified has a 68% chance of remaining in that state to practice. So while some states are looking at spending all kinds of money to create new schools, a handful are starting to recognize the criticality of increasing residency slots in rural areas. Let's do a little retrospective look. Iowa, a few years back, graduated 369 students, with 131 leaving the state because 238 positions were available. Missouri lost 186, Tennessee lost 200, and your import states, interestingly, are New York, California, Massachusetts, and Pennsylvania, primarily because those are the states where advanced medical education had its infancy back in the day. What about Arkansas? If every freshman graduates as a senior at UAMS, we graduate 174 students. As I mentioned, we now have 2 DO schools, one on each side of the state, one in Fort Smith and one in Jonesboro, Arkansas. All in, they will contribute an additional 270 students to create a total of 444. Last year, I did a survey to find out how many first-year positions we had in the state. You can see those before you. I won't read them, but we had a total of 217 first-year positions. So, a little math. You've got 444 graduates with only 217 first-year positions. We will, in fact, export 227 students, and that assumes that any student would take any residency position. If I want to be a pediatrician and the only opportunity is a surgical urological position, then I'm going to go elsewhere to get my pediatric residency. A little bit of math to show you the financial impact. All in for fees and tuition this last year, it cost somebody, a student in Arkansas, $138,627. Fees and tuition only, not looking at housing, transportation, and other things. The actual estimated cost of educating that student is $362,500. So you do the math, you end up with a difference of $223,873. So if you want to think about it, every student in Arkansas that leaves for elsewhere is also taking with them nearly $250,000. What is the financial impact of that to the state? 444 minus 217 leaves 227 times 223.8, $50 million of export for the state of Arkansas. I'm going to finish with digital health because I think that's where it has to go, at least as part of the solution for the rural area. Arkansas was so fortunate back in 2010 to receive a BTOP Broadband Technology Opportunity Grant of $102 million. With that, we were able to create over 450 T1 lines around the state in clinics, health departments, 2- and 4-year universities. We became at the time the most wired state in the nation, and on this network, we've been able to utilize it for the Arkansas Saves Telestroke program. This is where specialists, neurology specialists, will be able to virtually hold the hand of rural emergency doctors who are presented with a patient that has a thrombotic stroke to push lytic agents to recover brain. You can't wait on that. You have to do it at the point of care in the rural area. Dr. Curtis Lowry has developed a high-risk maternal fetal health program to reduce complications of high-risk pregnancies in the rural area. Blue Cross, in the last 2 months, has awarded $1 million once again to UAMS to enhance Dr. Lowry and his team with regard to the digital health enterprise at UAMS. So what's going on with digital health? Blue Cross is in the process of assisting clinics with receiving cameras so that diabetic retinal screening, this is a big deficiency. The typical numbers that I see in clinics is around 30% compliance. And these folks can go blind and not even know they're having a problem. This is low-hanging fruit that I think is perfect for a digital application. In addition to that, there are a number of other specialty services that are being provided around the state. So one that's interesting to me, this is a friend of mine, Dr. Stephen Cannon at Arkansas Children's Hospital. He's a pediatric urologist. Peds urology is a rare bird, let me tell you, and he's been able to work on a project to see small children with urological problems in the rural area of the state from a central location. In addition to that, Arkansas has the first Tele-Hand Trauma service. So Dr. Wyrick, you see, and her team carry iPads 24/7, 365. If someone shows up to an emergency room in Arkansas with an injury, they can be evaluated virtually right to that rural ER. This saves time, it saves resource, it saves digits, it saves limbs, and if the injury is one that's too catastrophic to be cared for in Arkansas, it can be appropriately referred on to another state specialty. Dr. Teo has a Tele-Burn program very similar to Tele-Hand. Someone shows up in the emergency room with a burn. It may look really impressive and severe to the physician or the nurse practitioner out in the rural area, when in fact it really wouldn't qualify to be in a burn unit like we have here in Little Rock. So she's able to guide therapy and importantly can keep care that really should stay home at the home facility, enhancing revenue margins and also facilitating convenience for both the patient and the family. The last slide talks about the newest program in Arkansas. It's our Telespine program. So we know that there are a lot of folks with chronic spine conditions. A well-intended primary care physician may refer that patient to UAMS for surgical intervention to get the patient out of pain. Patients can travel a long distance in our state to then see Dr. Pate and others, only to be told after the initial assessment that they're really not a good surgical candidate. So we now have trained telepresenters around the state in our regional programs. Those are the rural residency sites, and that can short-stop the patient having the initial evaluation via the web and keep them from coming all the way if they're not a good surgical candidate. It therefore frees up bricks and mortar space to allow those patients that are evaluated at UAMS to be more likely to benefit from surgery if offered. That is the conclusion of my presentation, and again, I appreciate the opportunity to participate.